Thanks for that introduction, Dr. Brown. Everyone hear me okay? I want to thank everybody for coming out today, especially the people who are here for a makeup who were scheduled back in February. This picture is actually Woodburn Hall in Morgantown, and the picture was taken a few days before the lecture we were supposed to have back in February. I can see all the anxiety it's given everyone with the thinking about the snow, so I seasonally updated it, so that's more appropriate. So again, I'm Don Mishra. I'm one of the interventional cardiologists with the WVU group here at Berkeley Medical Center. And tonight we're going to talk about an important topic, and that's coronary artery disease in women and what our objectives are. I always kind of like setting the groundwork for what we're going to talk about. So first we'll talk about epidemiology, which is really just the prevalence or occurrence and scope of that problem in our society. Then it's always important to know what you're talking about. I feel all of us probably have at least a decent grasp of women, that part of the topic. So the other part we may not have as good a grasp on is coronary artery disease. So we'll try to define that, talk about what that term actually means. And then we'll spend a good deal of time talking about the symptoms of coronary artery disease, both angina and also heart attack. Typical symptoms as well as symptoms that may be atypical and you may not think represent that disease process. We'll talk about what puts you at risk for coronary disease, and then once we've identified those risks, what we can do to help try to prevent or treat those risks. So my other objective is to present all this in an informative but light manner so you guys don't end up looking like this at the end of 60 minutes, except if you look like her, that's okay. She's pretty intense over there. She's focused. So the reason why we're here and the problem we're talking about is that cardiovascular disease is the number one killer of women in this country. And cardiovascular disease can be separated into a few different categories. One is heart attack or ischemic heart failure, also stroke, mini stroke, peripheral artery disease, and disease of the aorta. But coronary artery disease makes up the lion's share of that group of diseases, and actually coronary disease, even when separated out, is still the number one killer of American women. In fact, coronary disease is responsible for 1 in 3 deaths of women each year. To give you something to compare to, 1 in 31 deaths are from breast cancer. So for the visual learners in the audience, this slide really just shows what we've talked about in bar graph form. So this graph, or this bar, represents total cardiovascular disease. They've used CHD to abbreviate for coronary artery disease. So you can see coronary artery disease has significantly more deaths than cancer, asthma, COPD, and stroke as well. So in fact, to put in a somewhat sensationalistic statement, but true statement, 1 woman dies every minute from cardiovascular disease in the country. So that's 60 lives in the time it will take for this lecture, and that's assuming I stay on time schedule. So to illustrate this problem and look into why this is such a problem, a lot of it has to do with a lack of awareness that this is a problem, which is strange given how prevalent it seems to be. In fact, the AHA published a survey that was done of women in 2012, and it parodied a same survey or similar survey done in 1997, where they questioned 2,500 women who were over age 25. And initially it looks favoring. They asked these women what the leading cause of death was in the United States for women, and awareness of the study population doubled during that time period. So in that 15-year period, we doubled our awareness, but awareness was still only 56%. And I don't know about you guys, but every history test I've taken, 56% is an F. So certainly room for improvement. and even more troublesome in minorities, and minorities who actually have higher prevalences of coronary disease. Awareness is even lacking further still. Again, for our visual learners, this just shows what we talked about in bar graph format. So here in 1997, you can see only 1/3 of the surveyed Caucasian population were aware that coronary disease was the #1 killer of American women. And while we did have a significant increase over the next few years to 2006, we've really kind of plateaued and actually tailed off some over the next few years. And that's mirrored in our minority groups as well. So to focus on some good, part of the increase in awareness has really been attributed to the Heart Truth campaign, which was is a national campaign that's sponsored by the National Heart, Lung and Blood Institute, NIH, and the U.S. Department of Health. It's targeted at women aged 40 to 60 to really do just that, increase awareness that coronary artery disease is a big problem for women in this country, and help them further look into what their risk factors are and what they can do to address those risk factors for coronary disease. This was accompanied by the Red Dress campaign, which occurs every February. A lot of celebrities participate. It occurs on February 6th, where women are encouraged to wear red dresses. Lots of healthcare providers wear red to really just promote awareness for coronary artery disease being such a significant problem. All right, so on to defining coronary artery disease. You couldn't escape mini med school without an anatomy class, so we'll start off with anatomy and what our coronary arteries actually are. So we have a picture over here on the right side of the slide that's a diagram of the heart. The heart muscle itself is in gray. The aorta is this large red tube that's coming up and making a hairpin turn. The aorta is the main blood vessel for carrying blood away from the heart. It carries blood to all parts of the body. As soon as the aorta leaves the heart, it gives off two arteries, which are the coronary arteries. One on the left side, which then separates into the left anterior descending coronary artery, and it travels down the front side of the heart. The left circumflex, which this diagram only shows a small portion of, wraps around the side of the heart. And then on the right side, what else but the right coronary artery, cleverly named, that again wraps around and supplies blood to the back side of the heart. And each of these give off small respective branches, but mainly important for you guys to remember that there are three main coronary arteries: the left anterior descending, left circumflex, and right coronary artery. So we always pair anatomy with physiology. So what do the coronaries do? What's their responsibility? The coronary arteries give blood flow to the myocardium, which is just a term describing heart muscle. So these arteries give blood flow, and that blood carries oxygen and nutrients to the heart muscle. And remember, the heart has a really high oxygen and energy demand. For the average person, your heart's beating 70 to 80 times a minute, 60 minutes an hour, 24 hours a day, 365 days a year, and so on. So this consumes a lot of oxygen and energy. In a healthy heart arteries, whenever your heart activity increases, you exert yourself, your heart rate increases, there's a proportionate increase in blood flow to supply more oxygen and more nutrients for the demand that you're placing on your heart. When oxygen delivery doesn't equal what's being consumed, then we get angina as a result. And we'll talk more about what symptoms of angina are later, but you could think about angina as any symptoms that are coming from decreased blood flow to an area of heart muscle. And what causes those symptoms is the oxygen supply not meeting the oxygen demand. So on to pathology class. So what is usually responsible for causing this decrease in blood flow or decreased oxygen to the heart muscle is atherosclerosis. And that just means cholesterol blockages that are forming in the artery. So over here in this cartoon, you can see a nice normal artery, and here's cross section, just like you're looking down it, like looking down a pipe, and you can see the amount of area that blood's traveling through. In the lower picture, there's a cross section of an artery where cholesterol blockage has started to form, and you can see when looked at in cross section how that limits the lumen or area that blood can travel through to carry that oxygen to the heart muscle. On this slide, what we have is really just a timeline. This just shows you sort of the life course of a blockage in an artery. So in the beginning, atheroma or blockage formation starts with just endothelial dysfunction. Now there's a big term. What that means is it's just the inside layer of the artery. And what causes that endothelial dysfunction, or what you imagine are traditional risk factors, shear forces from having high blood pressure, having high cholesterol, and inflammation to the endothelium that is traditionally caused by things like smoking. This chronic injury makes that vessel wall permeable, and cholesterol can infiltrate the vessel wall and cause this blockage formation. And one thing I want to point out, because it'll be important in some of the slides we talk about later, you can see the earliest form of a blockage is the fatty streak, and that can occur as early as the first to second decade of life, which is earlier than what most would think these things start. Alright, so this video is just a video I found that I think demonstrates what we've talked about in the past few slides, but again, more for our visual learners. We'll show the progression of coronary disease to a lesion that would cause angina. Again, here, stylized version of the heart. And they're going to zoom in on the left anterior descending coronary artery. They'll show you all of them, but they'll zoom in here. So now we're traveling with red blood cells down the heart artery, or coronary. And over time, a cholesterol blockage is formed, and you can see the red blood cells having trouble getting past that lesion, and as a result, you're getting less oxygen carrying, less nutrient carrying blood vessels downstream. And over time, as the lesion progresses, becomes unstable, you can get clot formation that's associated, and again, less and less red blood cells carrying oxygen to their target, which is the heart muscle. This reduced oxygen getting to the heart muscle leads to what we said. Our supply of oxygen doesn't meet the demand that our heart requires, and that results in symptoms which can be angina. So as coronary disease progresses and plaques get larger, they can also become more unstable, and this can lead to total occlusion of a heart artery by either plaque or plaque and associated clot. And when total occlusion of an artery happens, that's a heart attack. When blood flow is terminated, if blood flow is not restored, any heart muscle that is downstream from the occlusion site can die. So again, for our visual learners, we've got another video. This video carries on what we looked at in the previous video and demonstrates a heart attack. So again, they're taking us in the left anterior descending. Here's a coronary blockage that's unstable. me pause it a sec and we'll talk about this. So this plaque is a thin fibrous cap, and there's liquid cholesterol inside the plaque. What we'll demonstrate in the video, these plaques can become unstable. So even though this plaque, if you look at the artery size of this plaque, you'd say, well, maybe it's 60% blockage, maybe 50% blockage. It could still lead to a significant coronary event, and this video will demonstrate that. As this plaque ruptures, you get that cholesterol, liquid cholesterol flowing into the vessel. And when that happens, when that plaque ruptures in the heart artery, your body sees it as a site of injury, and it rushes to treat it like it would an injury or a cut on your hand, and you form a clot there. That clot associated with the cholesterol in the vessel effectively completely blocks flow down that artery, and that leads to the heart attack. So what can we do to treat that? Well, procedures like balloon angioplasty, stent placement can reopen a blocked artery. My partners and I do procedures like that over in the cath lab that you guys will get a tour of. But it's important to remember that these procedures don't repair heart muscle that's already dead. So opening up a blockages to muscle that's already scarred won't really improve much at all. And in fact, if the condition worsens and is not treated, could obviously lead to permanent disability and death. And I guess the important take home, it's critical to realize there's no quick fix for coronary disease. And in fact, the best way to treat a heart attack is to make sure it doesn't happen in the first place. And that's what we'll try to stress in some of the further slides, what we can do to mitigate our risk factors and try to prevent these events from happening in the first place. To give you an idea about what angioplasty is, we've got another video. I was able to dig this up from a vast medical archive, otherwise known as YouTube, that I thought effectively demonstrated from beginning to end of what we do with angioplasty. So again, we have the heart here. They're showing us blood flow, and they're showing us a blockage that's narrowing one of the coronary arteries. This is not an acute heart attack. It's an elective procedure, but all this happens before a heart attack as well. An IV line's placed, your heart's monitored, and we provide sedation for the procedure. Let me stop this real quick. So what's happening here is a needle is being introduced into the femoral artery or artery in the leg. Now in this video, they're actually doing it on the left side. More commonly, this happens on the right side, and it's the only rhyme or reason to that is it's just because that's how our cath labs are set up. Nowadays, most of the procedures we do are actually via the radial artery or artery in the wrist. But there weren't as complete videos done from a radial approach. So the only difference is the site of entry. Everything else would remain the same for a radial artery procedure. So once access is obtained in the artery, a small guide wire is advanced up the femoral artery, up the aorta, and then around the arch of the aorta. From a radial approach, that wire would be coming down through this artery, the innominate artery, and into the aortic arch. Then a thin catheter or hose is advanced over that wire. Again, up the aorta, around the aortic arch. Once the catheter is in place, that wire is removed, and the catheter can then engage the coronary arteries. We then inject contrast into the heart arteries and take moving x-ray pictures. It's called fluoroscopy or cineangiography, but you can think of it as just like an x-ray movie. When you go over for the tour of the cath lab, they should have some films you can look at to get an idea of how the films really look to us and how we perform these procedures. This is sort of a cartoon rendition of what we actually do. But you can see the contrast being injected, which delineates that blockage that we saw earlier. So they take a couple shots here, identify the blockage. Which on their angiograms actually doesn't look quite as significant as it did on their cartoon. So here they have a wire down the coronary artery. So through that catheter that we saw in the previous slides, a wire is introduced through that catheter. The patient receives a blood thinner, so clots don't form on the wires we work on, very high doses of blood thinner. That wire is then advanced down the coronary artery across the lesion as it was in this picture. You see the wire here. Along that wire, a balloon catheter is placed. So when people say they got a balloon with their angioplasty or got a balloon in the cath lab, this is what they're talking about. This balloon can then be inflated from outside the body. So you see the balloon inflated, and they'll go through a progressive series of inflations here, slightly more pressure each time. Basically compressing the blockage against the wall and increasing the area that blood has to flow through the artery. Stent placement works the same way, wire down the artery, a balloon placed again. The only difference is the stent is crimped on the outside of that balloon. As the balloon's inflated, the stent expands. The balloon's deflated and the stent's left in place. And the balloon and wire removed, again increasing the lumen that blood travels through that artery. Alright, so now that we know what coronary disease is, what it can lead to, how do we know that it's a problem? What are the symptoms? What are the symptoms of heart attack? And what are the symptoms of angina? Classically, chest pain or chest discomfort, many people describe as angina. A lot of times angina is usually used to just be interchangeable with chest pain, but in fact angina can present in a multitude of ways, and these atypical presentations for angina can be very common in women. Unusual upper body discomfort, neck pain, pain between your shoulder blades, sometimes just shortness of breath, diaphoresis or breaking out in a cold sweat that's disproportional to the amount of exertion that you're doing, unusual or unexplained fatigue, lightheadedness, and nausea. So a study was actually published a little while ago in Circulation where they looked at 515 women who presented with, this says MI. MI means myocardial infarction. That's just medical ease for heart attack. So 515 women presented with heart attack. Of those 515 women, 43% didn't have chest pain when they presented. In that 43%, the most common symptom was shortness of breath, followed by weakness and fatigue. There was a fair proportion of women that actually had a prodrome. What prodrome means is those women had unusual symptoms in the 7 to 14 days leading up to when they had their heart attack. 71% of those with a prodrome, it was unusual fatigue. during that time period, followed by sleep disturbance and dyspnea, again, just means shortness of breath. So 1 million men and women were registered in the National Registry of MI, again, myocardial infarction or heart attack. And that happened between 94 and 2006. And about half of that population was represented by women. 42% of the women in that registry, again, presented without chest pain. This is compared to 31% of men. So still, even in men, for those men in the audience, at least 1/3 of men can present with atypical symptoms too. But the proportion certainly is higher in women. Women also had a higher in-hospital mortality, meaning higher chance of death in hospital associated with their heart attack than corresponding men. And younger women who presented without chest pain were one of the highest risk groups. More concerning and leading to more importance of recognizing these atypical symptoms is that the women who presented without chest pain were often sicker and fared worse. And a lot of this had to do with later presentation because of what we talked about in the beginning, a lack of awareness that those symptoms could be associated with a heart attack. As a result of their later presentation, more of them had advanced heart failure at the time of presentation because, as we talked about, when it comes to a heart attack, the old adage is time is muscle. So the longer it takes to present, the more chance that muscle has of not recovering. Not only is awareness, or can awareness be a problem with patients, but it can be a problem with providers too. So it's important for medical providers to recognize these atypical symptoms because in this registry, the women without chest pain received less timely therapies from the physicians, including blood thinners and other medicines we would use to treat a heart attack. So again, we come back to awareness, and here's that 15-year survey again that we talked about previously. And when they asked women what warning signs they would have with a heart attack, at first we think, well, we can pat ourselves on the back a little bit. This asterisk means that the statisticians have looked at it and said that that is a statistically significant difference. So we can pat ourselves on the back and say there's a significant difference in awareness that nausea can be a sign of a heart attack, that shortness of breath can be a sign of a heart attack. But again, these numbers are very small. Only 18% and 38% of the women surveyed were aware those could be symptoms. And what's more concerning to me when I look at this data is that when asked if chest pain could be a symptom of a heart attack, we've actually significantly decreased in our awareness over that 15-year time period. So what else leads to some of this late presentation we've talked about? Well, women being often the caretakers of the family, providing care to those around them, are more likely to encourage others who are having symptoms of a heart attack to present than actually responding themselves. And in this same survey, 80% of women, when asked what's the first thing they would do if someone around them had signs of a heart attack, answered they would call 911. That same population, 65% would call 911 if they themselves were experiencing the same symptoms. So this next video, I'm not sure how many of you are familiar with her. An actress named Elizabeth Banks. She's been in several movies over the past few years. She has a very significant family history of coronary disease. All of her sisters, her father and mother, suffer from coronary disease. So a couple years ago, she teamed up with the American Heart Association and made an awareness video that I think illustrates some of the concept on these previous slides.
It started out like a totally normal day. correction deadline to the third line after survey. Oh, honey, for when you are, you always use the verb estar. What are you doing down there? Did you finish your breakfast?
Ow.
Whew. Don't hit your brother. Honey, you have to eat something. Here. Okay, 5 minutes to carpool. Where's my coffee?
You okay, Mom?
Oh, I'm fine. Sandwich orders. What do you want?
Almond butter and jelly. Spaghetti. You sure you're okay?
I'm fine, sweetie.
I am so late. Hey, buddy, how you doing? Hey, honey. You okay?
Yeah, I'm fine.
You sure?
Oh, yeah. Here.
Acai, my favorite. See you guys later.
Wear your shoes. Put your shoes back on, please. You know, go help your sister. We're going in 3 minutes. Oh my God, what am I doing? I forgot to cut off the crust. Voila. Shoes on, potty if you need it. Honey, get your sister. Okay, get her shoes. Nobody move. I'm getting a dustpan. Oh.
Mom! I think you're having a heart attack.
Honey, do I look like the type of person who has a heart attack? I'm just gonna sit down. I'm totally fine. Don't forget to wear the high socks with the shin guards.
Forget about the shin guards, Mom.
Come on, Mrs. Underdog is not gonna wait. Whoa. Okay. 9, 1, 1. Hi, sorry to bother you. I think I might be having a little heart attack. Nothing really, just some nausea, tightening of the jaw, dizziness, shortness of breath, muscle pain, achiness, this terrible pressure in my chest. Oh, really? They can be here in how long? 2 minutes. Can you make it 10? I thought I had gas. Turns out I was having a heart attack. Heart disease is the #1 killer of American women. So now I take care of my heart and I tell the women in my life to do the same.
Sounds great, by the way.
That's nice, sweetie, but that's not my heart. That is. Make it your mission to save your life and the lives of the women you love. Find out more from the American Heart Association at goredforwomen.org.
So I think a good video just to illustrate some of the things we've talked about, some of the atypical symptoms, sometimes women's reluctance to seek medical attention for themselves because they're busy taking care of all those people around them. In fact, some of the cited reasons why women didn't take action for their heart attack or their heart disease were that many think it's a disease that's just for men or mainly associated with men. Again, a lot of times that their health isn't a top priority because they're busy taking care of their husbands, their families, their significant others. Many think they're not old enough to be at risk. And then a lot of times they feel like lifestyle changes they may need to prevent coronary artery disease would take time away from the other activities they're required to do in their life. So what we want to point out is one, of course, make yourself a top priority. Part of that is because that allows you to better take care of those around you when you yourself are looking out for your own health. And also, incorporating lifestyle changes for yourself allows you to do that for your families too, which is important because if you remember the timeline of atherosclerosis we looked at in the beginning, those precursor lesions are forming between the first and second decade of life. So important to make these changes for yourself, and they can trickle down to changes for your family as well. So a little of that tempered with some good news. So coronary disease, whether it's diagnosed significant coronary disease, can be controlled, or if it's precursor lesions, we can do our best to prevent it. Prevention includes lifestyle changes, and then sometimes, if those lifestyle changes aren't enough, medications prescribed by either your primary care doctor or a cardiologist. What we'll try to demonstrate in the next few slides is that whether you're young, middle-aged, or elderly, taking the appropriate steps to modify your risk factors makes a difference no matter your age. The first part of modifying risk factors is really to assess which risk group you're in, high, intermediate, or low, and that lets you know the urgency with which you and your doctors need to approach these risk factors. If you have diabetes, or you have a known artery disease in any arterial bed, either the coronary arteries or your carotid arteries or your aorta, or patients with end-stage renal disease on dialysis, that puts you in the high-risk group for developing coronary artery disease. Who are intermediate or moderate risk group? If you have one of any of these things, you fall in the moderate risk group. So smokers, those with hypertension, hyperlipidemia, family history, obesity, or physical inactivity. So who's our low risk group? Those lucky people who have none of what we talked about on the previous slides and who are living a healthy, active lifestyle. So what risk factors can you as prospective patients control? Smoking, high blood pressure, high cholesterol, your weight, your activity level, and then diabetes. What risk factors can't you control? Well, your family history, your parents are who they are. There's nothing you can do about that. In your age. Until we find the fountain of youth, there's nothing we can do about that either. But one encouraging point is that if you look at the length of this list compared to this list, you have a significant more amount of risk factors that you can control than those you can't. One thing I want to stress is this multiplier effect, and that's that the more risks you have, or the more risk factors you have, your risk for coronary artery disease exponentially increases. One risk factor doubles your risk, 2 quadruples your risk, and so on. And what we'll try to illustrate in the next slides is that 4 things: eating appropriate diets, being physically active, not smoking, and maintaining a healthy weight can actually significantly impact your risk of coronary disease. Really want to stress how important it is that if you smoke, to stop. For women who smoke have a 6-fold increase in risk of heart attack. It's 3 times for male smokers. In studies of smokers, risk was higher for women smokers than men, regardless of the count, regardless of age. So women smokers had a significantly higher risk than all their male counterparts. In fact, in women, smoking is associated with 50% of all heart events. Again, for the visual learners in bar graph form, if you smoke, this is for men and women. If you smoke 1 to 14 cigarettes a day, you're 3 times as likely to have a heart event as someone who has never smoked. 15 cigarettes a day and over, you're around 5.5 times as likely to have a heart event. Activity level. So this slide can be a little complex for a mini med school. So this side is relative risk. This side is, I don't want you to worry about the units of work done, but it's essentially work done with exercise. The thing I want to be the take home from this slide is that regular walking can significantly decrease your risk as much as other exercise. So just maintaining some form of activity or exercise is important and can lower your risk. Guidelines for how much activity to do. You really want to try to accumulate a minimum of 30 minutes of moderate intensity physical activity, all days preferably. or at least most days. If you need weight loss as part of your regimen or sustaining a recent weight loss, that should be 60 to 90 minutes of moderate activity, most preferably all days. All right, here come the groans. Unfortunately, body weight is associated with coronary disease, and increasing body weights can lead to increases in coronary events. What we have here again is relative risk of a heart event, and here we have a measurement called BMI, and if you're not familiar with that, it's body mass index, and that's weight in kilograms divided by height in meters squared. So before you start trying to convert your weight in pounds to kilograms and height in feet to meters, there are lots of handy apps either on the computer that you can get on your phone that you can put in pounds and feet and inches, and it'll tell you what your BMI is. So as your BMI increases, once you start to get over 25, you can see you start having an increased risk of heart events, and it really jumps up at a BMI of 27. For BMIs of 30 and above, near 5 and 6 times the risk of those with normal BMIs. For women, weight gain since age 18. Again, this is in kilograms, but there's about 2.2 pounds per kilogram. So over here, you can think of this as 20 to 40 pounds. So if you've had a 20 to 40 pound weight gain since age 18, you're about 2.5 times as likely to have a coronary event than counterparts without that gain. Weight gain of over 40 pounds, risk is 7.5 times. And unfortunately, in West Virginia, we're always, when it comes to obesity, one of the hot spots on the map here. So this is 2010, and you have us and Mississippi standing out. But the important part of this slide is that if you remember 2 slides ago, if your BMI is 30 or over, your risk of a cardiac event is drastically increased. Greater than equal to 30% of the female population of West Virginia in 2010 was over a BMI of 30. So what should we aim for with weight loss? We want to be smart about weight loss and make changes that we can carry forward and maintain. So we want to do that through an appropriate balance of regularized physical activity and modifying calorie intake. Our goals, I know easier said than done, are BMI between 18.5 and 24.9 and a waist circumference of less than 35 inches. These next risk factors, typically physician-treated and physician-guided treated risk factors: blood pressure, high cholesterol, and diabetes. You want to aim for the goals here on the slide. Again, target blood pressure of less than 120/80, ideally. Medical therapy if you're over 140/90. In terms of lipid therapy, depending on what your physician practices, you want to talk to your doctors about your ideal cholesterol goal, whether they follow the old guidelines or the new American College of Cardiology guidelines. And then with diabetes, targeting an A1C of less than 7%. And while most of the time this is physician-treated and physician-guided intervention of these risk factors, what I want to really stress in the next slide, pointing back to one of our other slides, is that there are changes that you can make so you can address some of these risk factors. For high blood pressure, a weight loss of as little as 10 pounds in multiple studies has been associated with drops in blood pressure of around at least 10 millimeters of mercury. A dash eating plan, which you can find this eating plan on the AHA, American Heart Association, American College of Cardiology websites, is a diet that's, as it says here, rich in fruits, vegetables, low-fat dairy products, can reduce blood pressure significantly, and we'll show some data in a little bit that supports that. Sodium restriction to less than 2,000 milligrams a day. I know the first response is, I don't put salt on anything. That's what all my patients tell me. And they're telling the truth. They don't put salt on anything, but the problem is a lot of the food producers are putting lots of hidden salt inside. So it's important to look at labels and see exactly how much sodium you're taking in. Further restriction to 1,500 milligrams a day has been shown multiple times to lead to significant blood pressure drops. Increasing physical activity again, and then also limiting alcohol to 1 drink a day. Excessive alcohol use can raise blood pressure. Remember, 1 drink is 12 ounces of beer, 5 ounces of wine, or 1.5 ounces of liquor. 1 glass does not equal 1 drink. So a little data on that DASH diet. So when they looked at patients on the DASH diet compared with just regular control diets, patients had around a 9.5 millimeter mercury drop in blood pressure. An African American patient actually had around a 12.5 millimeters of mercury drop with the DASH diet. Some of these dietary changes can make significant impacts in your cholesterol too. You just need to know sort of what goals to shoot for. Saturated fat, which again you can find on labels, you want to make sure that equals less than 7% of your calories a day. If it does, you can get an 8 to 10% reduction in your LDL. LDL is bad cholesterol. That's the most important component of your cholesterol panel that you should look at when your primary docs check your cholesterol. Your dietary cholesterol, you want less than 2,000 milligrams a day, and you can see the corresponding LDL reduction. Again, losing 10 pounds, you can see as much as a 5 to 8% reduction in LDL. And other dietary additions, either plant sterol or stanol esters, can be used to further lower your LDL. Preventative drug interactions. I just included this slide because especially for women, things have changed over the past couple years. Traditionally, you talk to a cardiologist, aspirin was one of the many things we would say they should put in the water because it benefited everyone. That still holds true for the high and moderate risk women, but if you're lucky enough to be in the low risk group, there have been a couple studies over the past 2 years that seem to suggest that the reduction in coronary events that low-risk women get doesn't outweigh the slight risk increase they have in gastrointestinal bleeding. So right now, aspirin if you're moderate and high risk, but no aspirin if you're lucky enough to be in the low group. So in summary, remember, really this is all about raising awareness, and remember that coronary disease is the #1 killer of women in this country. I really want you to take home what the warning signs of a heart attack are, especially for the women, the atypical signs we talked about: shortness of breath, diaphoresis, new unusual fatigue. But don't forget the basics. Remember that chest pressure, chest pain was in the majority of women presenting with heart attack. Listen to those warning signs, like in the video. Don't delay presentation. If you have those warning signs in a stable progression, and you're concerned, talk to your doctor about it, talk to a cardiologist about it. In an emergent setting, call 911 as in the video. When it comes to prevention, there's a lot of, I hope we've demonstrated you have a lot of control over your risk factors and you don't have to rely on just medicines, and that modifying those risk factors can make a difference in your risk for having a heart event. I think Carol's getting out her shepherd's crook to pull me off, so that's the end though. So thank you guys.